All right, so our projects are rather unique. Mr. Stavatsky had trialed out the hospice project in Fort Worth, but as far as I know, our TB project is pretty unique in the realm of the MIH progression. It is comprised in Ventura County by the companies represented here. I am a paramedic with Lifeline Medical Transport, and our partner agency was AMR and then their sister company Gold Coast. These are the representative transport agencies in Ventura County. Our county does not have transport resources with the fire department, so this makes up the entirety of the county's transporting EMS companies. The first one we're going to be talking about is our TB partnership. So our TB partnership arose from a conversation with Mike Tagman, who unfortunately could not be with us today, but who sat down with the Director of Public Health and basically asked the Director of Public Health, what can the ambulance agencies do for you? Where do you guys have a need? Where do you have a deficiency? Instead of us doing the research to try and figure out on our own our best guess of what we might be able to do for them, let's reach out to the other partners that we're working with and ask them where their needs exist. And this was one of the suggestions. So AMR Gold Coast and then Lifeline, the transport agencies, Ventura County EMS agency, which is represented here today by Julie Fry, who has joined us down here, as well as the TB clinic, Dr. Uldine Castell and Eva Reeder, who are the TB clinic heads in Ventura County. And they essentially suggested that they have a greater need than they have capacity to handle. It's a third of the world's population infected with TB. I don't necessarily want to contradict Dr. Kaufman in when she stated our numbers are low because TB numbers as a whole, as an infectious disease, are relatively low. That's true for our county. As far as a disease percentage, it's relatively low, but across the globe, it's an epidemic, a third of the population. And that's actually why our program is never going to get completely ahead of things, but I'll get to that in just a minute. And then the difference between the latent tuberculosis and then the active tuberculosis. Our county is seeking a 100% eradication of tuberculosis, which, like I just alluded to, may not be an achievable goal because we have a very ethnic population. Our borders are very porous, both internationally and across county lines. So we are always going to be working on getting closer and closer to that 100% number in our outreach. That was also one of the points of contention that arose when we first began training up our community paramedics, because these are guys who go home to their families and they were thinking, man, I'm going to be contacting these active tuberculosis patients regularly, all the time, scheduled, like I have to go into their house and spend time with them. And it created quite a bit of concern. And I'd like to thank Dr. Castell and Eva Reeder for helping show us we see these people every day. This is our job. And if you take proper precautions, it's not going to be a significant concern. It's just a matter of preparedness and understanding. And then what we're actually accomplishing for them is assisting in the directly observed therapy of these patients. So like Dr. Kaufman spoke to earlier, we are going out and we are watching these patients take their medication. So specifically for multiple drug-resistant instances of tuberculosis, if it's not followed stringently, it can actually become much worse of a disease process if the care plan is not strictly followed. So as a county, reaching out to attempt, again, to get that 100% number, we watch nearly every dosage of medication taken by the patient ingested to ensure that they're following the care plan that is developed by the county. And those care plans, I do need to reiterate, are developed by the county and are legally placed on the patient. The patient does not have the ability to say, I don't really want to take TB meds. This cough will get better in a bit. It's something that we are doing on behalf of the TB agency from a legal standpoint to ensure that it is being done. This is our beloved county. It's a beautiful place if you guys have not been. It's about 2,200 square miles. It's about 840,000 population, give or take, mostly clustered down there in the south. This is where the TB clinic is, situated right down there. So you've got one doctor and a handful of nurses and then a handful of chows, which are the community health workers. that are responsible for ensuring that any identified TB patient within this geographic area receives their medications in a directly observed therapy format. I know that the numbers here listed were, and we'll get to those in just a second, were relatively low, but that ends up being a massive undertaking given the geographic area and the population to reach out to each one of these people, and every time that pill goes in their mouth, someone is there to watch it. So this is where the need arose from the county TB clinic standpoint. They could not get to everything. They just did not have the infrastructure, and that's where we come in. So they are a Monday through Friday. They're off on weekends and holidays. If somebody were to be scheduled for 4 o'clock and say, hey, I'm in traffic in LA, I won't be able to make it till 7, they don't have the flexibility really to go beyond that. And then mobility, they had a couple little cars that they would send these chows out in the field to meet up with these patients in, but just a couple. Whereas we bring to the table units spread all the way across the county that operate 24 hours a day, 7 days a week, and the ability to reach out to each one of these patients in a much easier format. So our standard DOT patient, this actually is Mr. Schultz here. Our standard DOT is one that is going to be scheduled generally after the business hours. If everyone that the clinic had said, sure, I can come to you and I can be there between 8 and 5, Monday through Friday, well, then there may not necessarily be a need for us. So the ones that tend to push onto the community paramedics are going to be the ones where they work in LA and just get back up to Ventura 8, 10, whatever time at night, and we can go out to them, or early morning before they go to work. We can catch those types of people. So we're going to be oftentimes interacting with these folks at night, oftentimes in their home, sometimes possibly at work. We go out to them. We have the medications with us. We have documentation of the dosages that have been prescribed to them by Dr. Castell in the TB clinic, and we administer those medications. The standard assortment of medications that are given is known as RIPE. They are represented here. We have had a few patients that were drug resistant, multi-drug resistant. There was one documented case of an XDR, an extreme drug resistant patient. And that's ultimately what we're trying to prevent by having these DOTs performed in a timely fashion. So some of the benefits that are provided by a paramedic going out to these calls, that is just beyond the logistics. So sending a paramedic out to these calls as opposed to a chow, which is more of like an office assistant, a healthcare office assistant. If you send out a paramedic, we have the ability to assess the patients while we are there. So not only can we watch them take the medication, but we can also ask them, are you guys having any issues with these medications? Have there been any side effects? Any trouble breathing? Are your joints starting to hurt, which is a side effect of some of the medications? And we can provide a little bit of assessment that goes along with that to become even more of an extension of the eyes and the ears of Dr. Castell and Eva Reeder in the clinic in managing the care of those patients. Additionally, we have participated in contact investigations, which is where if you have an identified TB case, you go back and you look, where was this person during the time period where they could have actively transmitted that to other people? Because every person they became in contact with would then be a suspect for having TB and would have to be tested. This can be as simple as you go to someone's house, there are 3 or 4 people in that house, we test them, we're done. It can be as complex as going to an entire high school, hundreds of people who need to be tested to find out what was your contact with this person, identifying whether or not we have to test that person for tuberculosis and then include them into the therapy from that point forward. So that's another way that we have found to assist the TB agency. As far as the cost for the providers, there is no realized cost for the providers in our county. Both of our projects are performed by our paramedic supervisors. So there are 4 paramedic supervisors that are on duty in our county 24 hours a day, 7 days a week, geographically separated throughout. Those 12 people, plus a couple extra, so 14 total, were a part of the initial training that took place over the course of, I think, 18 weeks was our training. So these are people that are already out there in the field. They are already popcorning all over the county to manage any need that arises that should fall into their purview. We just took this and essentially added that as one of their essential duties, was to take this expanded patient outreach and plug it into their schedule on a daily basis. So these are pre-scheduled by the TB clinic. These are patients who Eva at the clinic identifies, says you are going to be assigned to EMS 63 or EMS 51, and you're going to meet this guy at 10 o'clock at night, Tuesday and Thursday. And we make it out to these patients with the medications in a locked, zipped bag and document all of the things that transpire, and we care for that patient from that point forward. They still have scheduled office visits, but they kind of become our responsibility from the DOT perspective. Oh, there is, it's worth mentioning, though, that there is a opportunity cost. There's no realized cost because we're utilizing existing resources, but there is the opportunity cost. Thankfully for the DOT project, it is relatively minimal. If we are able to get to those patients, by the time we've been with them for a couple months, these visits tend to be more about how is your wife and kids and what's going on with your dog after the vet and that kind of stuff. But the actual DOT only takes 5 to 15 minutes for most of these patients based on the complexity of the side effects that they may have. It becomes rather quick. Additional cost savings for the clinic. They were having to utilize bubble packs before, which are more expensive. It doesn't change their reimbursement from the insurance agencies that they attempt to bill. But now with the community paramedic under the pilot, we are able to utilize bottles of medication, which are significantly less. So reduce the cost per DOT that they had been performing. And then obviously we're transitioning their vehicle and gas maintenance over to ours. But ours is less than theirs would be, because if EMS 42 needs to go to a DOT patient, he maybe only has to drive 4 or 5 miles, whereas the chow may have had to drive an hour to get to this person. So lessens it overall. And then reducing the clinic overtime if they had weekend patients. So as far as our actual numbers, 46 patients total since the partnership began. So this actually was extant prior to the pilot. This is something that had been going on prior. It's changed a little bit because under the pilot, we are able to give medications out of a bottle of medications rather than take the bubble packs, which is much, much easier. And so in the pilot phase, we've had a total of 29 patients, with 3 of those being multi-drug resistant patients. And these numbers are a little misleading because this can be as simple as EMS 51 gets a patient, you need to meet him Tuesdays and Thursdays at 7. That would be one of the most simplest cases that I could possibly imagine. It can be as great as 2 times a day, 7 days a week. One of those numbers would need to be contacted by a community paramedic. So the commitment is very, very wide in spectrum. And also keeping in mind that each one of those numbers represents between 6 to 9 months of that type of therapy. This is not an episodic go out, interact with someone, make a clinical decision over the course of 45 minutes and affect the change of the community paramedic. This is a very, very long-term relationship building type of pilot. So, what the data doesn't show, Jeff and I are actually filling in, so I'm going to pass those 2 off to him when we finish the slides. So I'm going to power through the hospice component, and then he's going to talk to you a little bit more about the boots on the ground aspects. So the hospice project. This is one that is pretty well established out in Fort Worth with Mr. Zavadsky, and this is one that we have taken on as well, and has actually been really successful. So again, many of the same partners, Lifeline and then AMR Gold Coast, our Ventura County EMS agency, quite a few hospice providers, which is kind of a moving target that we have found as hospice agencies come into the county or leave the county or change names, or hospice agencies that are across county line where the patient actually lives within our county borders. That's one of the most dynamic components of managing this project, is keeping up with that list. So keeping up with the list of patients, which I know Dr. Kaufman alluded to, we actually determined was not feasible. It was unreasonable to have our dispatch organization maintain a daily list of patients, their locations, and be able to identify them during call intake. So what we have now is a little bit different, and I'd like to add some partners to this list, which are the fire agencies in combination with AMR, Gold Coast, and Lifeline. The first responders, when they arrive on scene, have the opportunity to identify very quickly whether or not that person is a hospice patient. They will then initiate. They are the gatekeepers then to the hospice provider system. Ventura County Fire, which I see a lot of the black bands on the badges today. Wish I had one. You know, we're all in mourning for their loss, but they've been a great partner in this process with us in identifying these patients. So they will identify upon arrival, this is a hospice patient. They quickly, and our people have been fantastic about this, make a phone call to either dispatch or the community paramedic, identify that we have one. The community paramedic will then respond to the scene, making contact, the community paramedic, making contact with the scene crew to get a scene assessment, making contact with the hospice agency to determine that they're aware of it and that they are responding, what their ETA is to the scene, and then developing a real-time care plan for that patient based upon what is happening at the scene. So all of this happens very quickly, and this is what we hope to accomplish. So hospice is intended to provide people with a smooth transition into death. Once it has been identified that they have a condition that will likely result in death within 6 months, they are eligible to go into hospice with the intention they will not necessarily have to die in a hospital setting, tubes in their arms, ventilator in place. These are people who have a pulse, the DNR, who would like to be home with their family and die in peace. And ultimately, our project is intended to honor that to the best of our capability. And then family support, that is a huge component. So our community paramedics, as part of our 18-week training, work directly with hospice nurses who came in and taught us upon the curriculum that the hospice agencies utilize for their own people. It takes the medical care of that patient away from the traditional kind of Title 22 component of your base hospital physician is directing the care of your patient, or your personal medical directors, your agency's medical directors' policies directing treatment, and transition it over to us being an extension of the hospice agency. So they already have a care plan in place for this person. They already know this person. What we're attempting to do is to fill the gap that exists here. When 911 is called, the family oftentimes is the one who's calling, and they are calling for a reason. And then the hospice nurse arriving to provide care, or I'd like to add one in there, which is transported by 911. The community paramedic is intended to be wedged right in there to have the conversations that may ultimately result in honoring the patient's wishes, the wishes that had been written down prior on their hospice agreement. So we're going in and we're talking to the hospice agency, we're talking to the family, we're talking to the patient, and we're trying to help them to understand the ramifications of their decisions and to try and reorient them to the patient's intended wishes, which was, I would like to die at home with my family. Oftentimes, the process of death is very, very scary, and these people who may have never seen it before in their lives come into contact with someone who is actively in the dying process and just get scared. Whether the patient is going through it or whether the family is having trouble with it, either way, we have found that the conversation is the most important component of this. We originally thought that we were going to go in there and we were going to access the comfort care pack that is provided by the hospice agencies that contains medications to ease shortness of breath and to ease constipation and pain and all of these other items that the hospice agencies manage as part of the dying process. The reality is we've only accessed the comfort care pack in 1% of the calls. Every single one of these calls has resulted in conversation, and that has become the most important component of what it is that we do. And dealing with family members that may not be present, getting them on the phone, dealing with anybody involved in that situation to allow everyone to understand that the patient's wishes are still the same, and if they go into the hospital, here's what you can expect. It's going to be different for every patient, but oftentimes it could result in revocation of hospice and a much more challenging path to that patient's dying process. All right, so as far as cost, we have the same opportunity cost that we had before because we have these community paramedics that are committed to these calls. The opportunity cost is slightly greater for the hospice program because of the length of commitment. So where a DOT call can take between 15 minutes and a half an hour on average, a hospice call can take as much as 4 or 5 hours I know that Jeff was committed to one where he actually had to follow up to multiple locations with family to try and achieve the resolution that we really wanted to accomplish in this program. And then obviously ambulances in California get paid by the mile in addition to base rate, and we are completely negating our opportunity to get paid for the transport of these patients. But this is one of those instances where what is best for the patient is really what needs to be our focus, and we're going to try and accomplish that to the best of our ability, which we've actually done really well. We have gone from roughly, I think, 80% down to roughly 40% of the times where 911 was called and the patient being transported into an acute care facility. So statistically, a pretty massive drop in the amount of patients that are transported by this slide you would deem possibly unnecessarily prior, that we are now allowing them and the family to go through the process of dying that they had intended to go through. All right, so at this point I'm going to pass it off to Jeff Schultz. He's one of the more prolific community paramedics in our community, and he's going to talk a little bit about some of his personal experiences in the management of this program, and then we'll get to questions if that's okay.
Touch on a couple things real quick. First, I'd like to thank Leslie Simmons. She's our guru for data collection. Awesome. Thank you so much. Thank you, James, for filling in. Also, I just want to touch up real quick what Sandra mentioned. Providers, we're not looking at this to make money. We're actually losing money. This is for the betterment of the society, of the community, for healthcare. We're doing this for the right reasons. It's awesome. Thank you for being on board. Everybody here, thank you for all that you're doing. I'm proud to be a part of it. It's amazing to be part of change. I'm sure you all have been part of change in your careers up to this point, and this is just another chapter. So thank you very much. It's huge. We know that financial reasons are why a lot of these things happen. This is for the right reasons, and it's really great to see. Like I said, I'm proud to be a part of it. First, I'll touch on TB real quick. We get to go into people's homes, and they trust us. We're able to identify issues that other people can't. People thought, just like James mentioned from the slides, TB, well, that's eradicated TB. No, it's huge. The difference between latent TB and TB, if people aren't aware, if somebody is tested with latent, they have TB, they're just not sick with it. However, 5 to 10% of those people will become sick with TB in their lifetime. I pulled that off a CDC website. So the potential to infect more people. We did do a high school contact investigation as well, and there were hundreds of people talk about paperwork and consent forms. It was just an ordeal, but it's good to be a part of that. The multi-drug resistant patients were able to identify issues more than a couple times. We're able to identify issues where the patient had to be hospitalized. Scary thing when you have a disease like TB and somebody is multi-drug resistant. What that means for society as a whole, it's very important for us to have that. Taking an office worker and being able to identify things, we're able to treat for nausea, we're able to identify nausea, get in contact with the nurse or the doctor, and have the patient's medications that he already had, instruct them how to take the medication. So it's huge to be able to do that. And do you want me to just go into hospice and then do questions afterwards, or? Okay, thank you. I'm trying to keep it brief. Okay, so I'll touch on the first hospice call that we ran on in the county. One of our community paramedics was able to identify a patient who called 911 who only had health care in the daytime hours. So she was home alone in the evening. I believe that she had a fall, and he was able to identify that this patient needed full-time care. He's able to get a hold of the family and the hospice provider and was able to arrange full-time care for this patient. The patient died 2 weeks later at home with her family. She wasn't alone. You cannot put a price on that for this is what this patient wanted. We were able to identify that. Just like everybody mentioned in the past, we're doing so much more to be there. Everybody here, it's not a debate of whether paramedics are better than nurses or doctors. There is not enough time for all of us in the healthcare industry. So if a doctor could spend 4 hours with a patient, he would be able to go to their home and identify these things that we're able to identify. We're in a unique position to identify those things. We are investigators by nature. That is our job. We go into a situation, we try to figure out what's going on with that patient, sick or not sick, investigate. We identify things where other people, we're all trained in different levels. Nurses are great at what they do. Doctors are great at what they do. I just think, like everybody stated, we're a great adjunct to that. And, team effort, it's like we're all talking about. It's great to be part of a team. And I think if we can all get past in the industry of, who's better than everybody else, if we could just be a team, I think we're just a great adjunct to that. As James mentioned, one of my hospice patients I ran on was a 46-year-old male. He had a fall in his bedroom, and it came down to they just found out he had terminal cancer. He had maybe a month to live. He had 2 young children, a wife, and it was just too much for his wife to handle. She did not want him to die at home. Even though they signed him up for hospice, a lot of it is the misunderstanding where they're told that the patient has a terminal illness and this is your option because it's going to open all these doors for things that you can access, and they don't quite get it. And when it actually happens, so I actually followed this patient to Kaiser, and I sat with a case manager, and we were able to get placement for this patient in a home. And, just you're not going to get that by initial intake appointment a lot of the times. And we're able to be in places and have eyes for other people. And the time factor, family members, a lot of our callers are family members that are not ordinarily there. They come and visit. Oh, my goodness. Mom is not doing well, we need to get her to the hospital. Well, is that what mom wants or not? So it's just great for us to be there. I know I want to keep it short, so I'll open it up for questions.